while we are live.
Yeah, thank you. Good evening, all of you. Today is joining this virtual postgraduate teaching program of API-ICP. This evening, we are going to discuss a case on respiratory system, more specifically about the pleural effusion. We have Dr. Jagadish, the postgraduate from Salem Medical College, who will present this case. And we have two faculties for this evening. Dr. Vijay Rajasar, Professor of Medicine from GKNMC, is joining as a faculty from Department of Medicine. And Dr. Anandeshwari, Assistant Professor of Thoracic Medicine, is joining as a faculty from the Specialty Department. And over to Dr. Jagadish and
Yes,
Anandeshwari, Madam. Can you please discuss this case step by step from the history and past history, present history, so that we discuss in detail, because we have to discuss this case till at least 10 o'clock. Okay? So take this time to completely detail. Even question can be in the form of undergraduate level, doesn't matter. It is only the way of assisting the presentation and making use of this platform to ask more questions. Let him get exposed. Jagadish get exposed for more type of commonly asked questions in the examination. So that's beneficial to every postgraduate. I hope I'm clear to you, Dr. Anandeshwari.
Yes, sir. Yes, sir.
Yeah. Please, Dr. Jagadish, please go ahead.
Good evening, all. Thank you, sir. Shall I present case? 37-year-old male who is a clerk by occupation, belonging to upper middle socioeconomic status, coming from Omulu with complaints of cough for past 20 days, breathlessness for past 15 days. History of present illness, complaints of cough for past 20 days, which was insidious in onset and progressive in nature and non-productive, not associated with postural and seasonal variation, no history of aggravating or relieving factor, no history of nocturnal cough. Complaints of breathlessness for past 15 days, which was insidious in onset and progressive in nature. Initially, it was a MRC grade 1, which is progressed to MRC grade 2 over the past 3 days, not associated with PND, paroxysmal nocturnal dyspnea or orthopnea, not associated with the seasonal or diurnal postural variation, no history of V's. History of chest pain, which is localized to right side of a chest wall, which is a stabbing type of a catchy pain occurring with deep inspiration or cough, which is not a radiating pain, relieved by lying on the right lateral side, not associated with sweating, palpitation, or syncope. There's a history of fever for past 15 days, which is continuous low grade, not associated with chills or rigor, not associated with evening raise or temperature, not associated with night sweat, which is relieved by medication. There's a history of weight loss. There's a history of loss of appetite, no history of weight loss, no history of coughing of blood, no history of easy fatigability, no history of nasal discharge or nasal bleed. There's no history of palpitation, no history of swelling of legs, no history of abdominal distension or right hypochondrial pain. There's no history of facial puffiness or decreased urine output, no history of hoarseness of voice, regurgitation of food, no history of difficulty in swallowing, no history of joint pain or joint swelling, oral ulcers, alopecia, or skin rashes, no history of trauma. In past history,
so from first slide, so cough. So from this cough, what do you infer? So this cough is related to
this is a non-dry cough, non-productive, which is there
is no posture or seasonal variation. So it could be due to
pleural pathology or interstitial lung disease,
or interstitial lung disease, or it can be even GIT issues also.
GIT, yes, ma'am.
PD can be there. Yes, it is non-productive, so it doesn't come under parenchymal.
Parenchymal, yes.
Parenchymal. Then second slide, breathlessness.
Yes,
so it's insidious, progressive in
nature. Yes,
and it is not associated with PND orthopnea. So cardiac issue, somewhat it is ruled out.
Yes, ma'am.
And there is no seasonal or diurnal variation. So we are not landing up in asthma or COPD and all. There is no V's also.
Yes. Yes,
then third slide. So chest pain. So it is loculated, it is pinpointed on the right side,
Yes, ma'am.
single point. So it is not radiating,
Yes,
and
ma'am.
it is radiated by lying on the right side when it is given pressure.
Yes, ma'am.
So again, it comes in terms of
Pleural pathology.
pleural pathology. Okay. So you have ruled out all the cardiac histories,
Yes, ma'am.
renal history,
Yes,
everything.
ma'am. Yes, ma'am.
Good. Proceed. Doctor, please proceed.
Yes. In past history, there is no similar illness present in the past. It's not a known case of hypertension, diabetes, CAD, and renal disease, and CVA, epilepsy, thyroid disorders, and retroviral infection past, and COVID infection. Patient was vaccinated with Covishield vaccine 2 doses 2 years back. No history of examples, fever, tooth extraction, or trauma, or near drowning experience, or loss of consciousness. No history of foreign body aspiration, no history of exposure to STDs, no history of recurrent respiratory tract infections, no history of surgery or blood transfusion in the past, no history of recent contact with the active TB patient, no history of hospitalization or evaluation underdone for above complaint elsewhere, or no history of influenza vaccines previously. Family history, no similar illness in his family. History of his family members of 4 members living with wife, daughter, and son. No history of allergy or inherited disorder running in his family. In environmental history, his family is residing in a cemented roof top house with one hall with door, one small room with a window and kitchen. Without vent, it is a less crowded area. According to modified Kupaswamy scale, his family belongs to upper middle class. History of usage of gas stove, no history of smoke producing factory, firewood usage, garbage burning, running of heavy automobile around his house, no history of pet renting in his house. In the personal history, patient was smoker for past 15 years, discontinued since last 2 years. He used to smoke one pack of cigarette, which is 10 number per day. No history of number of pack years 15. Smoke index is 150. It takes a mixed diet. Normal bowel and bladder habit, is not alcoholic or beaten sugar. No history of any drug or dust allergies. No history of extramarital contact. In occupation history, patients are clerk by occupation for past 10 years. My summary is 37-year-old male, a smoker with no significant past history, present with complaints of cough without expectation for past 20 days, associated with pleuritic type of right side chest pain. Breathlessness progressed from MR grade 1 to past 15 days, associated with the fever. Problem system involved is respiratory system. My anatomical diagnosis, right pleural disease. Pathologic diagnosis, pleural effusion. Etiologic diagnosis, musculoskeletal tuberculosis, and bacterial infection causing empyema with no evidence of carpal nail.
Jagdish,
Yes, sir.
can you enumerate the causes for dry cough?
So dry cough, pleural pathology, pleural disease, sir. Then interstitial lung disease. Then
what are the drugs can produce dry cough? Common drugs.
AEC inhibitors, enalapril can cause. Then
common in children. What are the causes for dry cough? What is tropical eosinophilius syndrome?
yes, post-nasal drips, sir.
Post-nasal drip.
Yes.
There are dry cough, most of nocturnal.
Yes, sir.
So you told one of the patient going for empyema, but the patient having only low-grade fever, you told.
Yes, sir.
And why you are suspecting empyema in the by history?
It's Acute onset, sir. Patient having a progressive listening with
It's not acute onset. Patient having disease is going for subacute to chronic.
sir.
The patient by history,
Yes, sir.
it is acute onset rather than acute onset, and patient almost the disease is not progressing.
Yes, sir.
It is after admission. What is his status of pleuritic chest pain and breathlessness? After admission, what happened?
After admission, after antibody coverage,
How many days he is in the hospital?
is 5 days. Is for 1 week hospitalized, sir. After 3 days, is relief of chest pain, sir. Is breathless also relief after 3 days, sir.
Can empyema which will be relieved so quickly?
No, sir. With tubercular pathology may be cause, sir.
What are the other causes? Occupational lung disease can prediction to pleural.
The asbestosis can cause pleural effusion, sir.
So you told the patient is a chronic smoker.
Yes, sir.
So is this history significant?
Yes, sir. The back year is 15 years, sir. It doesn't correlate with COPD. You can go for COPD. After 30 pack years, we can suspect risk respiratory illness, sir.
So if you suspect tuberculosis, so tell me the natural history of tuberculosis. So when the patient will get a pleural effusion after exposure, when the patient will get a tuberculous meningitis, when the patient will get a primary pulmonary tuberculosis, or when the patient will get a genital or urogenital tuberculosis. So what is the natural history of tuberculosis? Tell me the timetable of tuberculosis.
So only 5% of a patient will exposed to the patient, exposed to TB patient will produce symptom at the time, sir. After it will become a latent in the lungs, sir. After
what is the timetable for tuberculosis? So when you have a history, you told he is exposing to so many patients or so many persons which may not be evident that he is having tuberculosis.
Yes, sir.
So what is the timetable for tuberculosis? So when you expect to get a pleural effusion, extra pulmonary tuberculosis, when you get a primary pulmonary tuberculosis. So when you get a tuberculosis?
The patient, when the patient become immuno suppressed, yes, sir.
What is the time interval to develop this disease?
No, sir.
So at least 6 months required to develop the extra pulmonary tuberculosis. So longest incubation period needed to develop genitourinary tuberculosis and your osteomyelitis. These are all taking at least 5 to 10 years.
Yes, sir.
Sure. Proceed.
On general examination, patient conscious, oriented, moderate build, moderate nourished, not dyspneic or tachypneic, no pallor, no ictus, no sinus, no clubbing, no pedal edema, no lymphadenopathy, no external markers of tuberculosis or sarcoidosis, no signs of Horner syndrome, acanthosis nigrans, small muscle wasting of hand, gynecomastia, and thyroid is normal. Respiratory rate is 96 per.
When you suspect pleural disease, which lymphadenopathy you have to carefully examine?
It's the axillary lymph nodes, sir, and intermammary lymph nodes, sir. Axillary lymph nodes and internal mammary lymph nodes, sir. Internal mammary lymph node.
Where is the bright of pleural veins? Where is the visceral pleural veins?
So parietal pleura drains the axillary nodes, sir. So visceral pleura directly right side and left side lower lobe drains into the right supraclavicular, sir. Left upper lobe drains into the left supraclavicular nodes.
So what are the other causes for patient tuberculosis? Is there any history of night sweating?
So no, sir.
Huh?
No night sweating, sir.
So what are the other causes for night sweating?
It's HIV and Hodgkin's lymphoma.
Which viral disease are encouraged to develop night sweats?
So HIV, human immunodeficiency virus.
Infectious mononucleosis. Exchange infection.
Yes, sir.
So how do you differentiate the examine night rise of temperature? What is the diurnal variation of temperature?
So morning is 6 a.m. is a normal temperature 98.6. In 98.6 morning is at evening at 6 a.m. 1 degree Fahrenheit increase, sir. 99.6 normal, sir. Sir?
The patient will tell evening rise of temperature.
So in tuberculosis patient will tell evening rise in temperature. Sir?
Normally there is a diurnal variation, no?
Yes, sir. But
Evening rise of temperature.
Actually, the cortisol level decreases by diurnal variations there, sir. So at the time, the patient will feel more of fevers.
When it is significant. When you say the evening rise of temperature.
Yes, sir.
4 degree
More, so 99.6 malapurus. 99.6 degree Fahrenheit.
Okay, proceed.
Yes. Vitals is pulse rate is 96 per minute, regular rhythm, normal in volume, character, equal filter on both sides, no vessel wall thickening, built in all peripheral pulses. Blood pressure is 120 80 mmHg in right upper limb sitting position. Respiratory rate is 18 per minute, abdominal thoracic, regular rhythm, saturation 96 in room air, temperature is 98.7 degree Fahrenheit. JVP is not elevated. Weight is 55 kg, height is 165 centimeter, 166 centimeter, and BMI is 20. On inspection, upper respiratory tract, nose examination, external nose is normal, no flared ala, no nasal deviated nasal septum or turbinate hypertrophy, no nasal discharge or crest or polyp, no sinus tenderness, no oral cavity, gum and buccal mucosa, lip, they have nicotine stain present, oral hygiene is good, no halitosis, teeth, tongue, tonsil, pillar, pharynx are normal, and low respiratory tract. On examining the patient from front with arms by the side of the body, trachea appears to be in a midline. Trial signs negative. Apical impulse visible half-inch medial to the midclavicular line. Chest wall symmetrical. Chest movement appears to be reduced on the right side. No hollowness, no rib crowning or intercostal retraction. Level of nipple at the same level, no gynecomastia. Axillary muscles of respiration are not in action. No chest wall deformities. No sinuses, cars, dilated veins over the chest, vesicles and nodules present. No bulging, no cholesterol bulging, no cough impulse. On examining back of the patient in standing position with arm or hang by the side of the body. No drooping of our shoulders. No prominence of medial border of scapula. No spinal deformities. On palpation, no warmth. Trachea appears to be on midline, confirmed to be in midline. Apical impulse was felt in left 5th intercostal space, half inch medial to the midclavicle line. No subcutaneous emphysema. Intercostal tenderness present. The right lateral chest wall. No crowning of ribs. Chest expansion, apical area, bilateral symmetrical, anterior chest bilateral symmetrical, lower anterior chest reduced on the right side, posterior thoracic movement reduced on the right side. Chest measurements, anteroposterior diameter is 20 centimeter, transverse diameter is 27 centimeter, and ratio is 5:6.75. Chest circumference on deep inspiration 87 centimeter, on expiration 83 centimeter, which is difference of 4 centimeter. Right hemothorax 42.5 centimeter. On expiration 41 centimeter. It is 1.5 centimeter. In left hemithorax 44.5 centimeter on inspiration. On expiration 42 centimeter. Difference is 22.5 centimeter. In spino-scapular distance in the right side 11 and left side 11, and spino-acromial distance 18, right side left side 18. Vocal formators in right memory area decrease. Axillary as right axillary and infraaxillary, interscapular, infrascapular is absence. On percussion, memory, axillary, infraaxillary, interscapular, infrascapular are stony dull in the right side. In tidal percussion, dullness in the right intercostal space, and on deep inspiration also dullness present. So tidal percussion negative. Top space tympanic in resonance, and percussion tenderness present the right lateral chest wall. No straight line or shifting nullness present. On auscultation, memory right side memory regions reduced, diminished, and right side axillary, infraaxillary, interscapular, infrascapular is absence. In vocal resonance, in mammary areas decreased, and axillary, infraaxillary, interscapular, infrascapular are absent. Absence. No added sounds, no bronchophony, no egophony, no whistling pituitary presence. On other system examination, CBS S1 both heart sounds heard, no murmur, perabdomen soft, no abnormality or no tenderness, and CNS moves all phones, and no asterix present. Consideration of examination finding. Trachea appears to be trachea is midline, reduced chest movement on right side, reduced chest expansion on right side, right intercostal tenderness present, decrease vocal formatus, vocal resonance in the right memory, axillary, infraaxillary, infraaxillary area, along with absent vesicular breath sound with no added sounds. Stony dullness noted in the right axillary, infraaxillary, infrascapular, and memory region, and no shifting and straight line dullness present. My anatomical diagnosis, right pleural disease. Pathology diagnosis, right pleural effusion, probably empyema. Etiology diagnosis, bacterial infection, primary empyema, and or tubercle etiology. Sir. Yes, sir.
Ranandeshwari, please ask questions.
Yes, sir. So you mentioned about intercostal tenderness, doctor.
Yes, ma'am.
Where is the intercostal tenderness?
And 4th, 5th, 6th, 4 and 5th intercostal space in right side of chest wall, ma'am. Lateral side, in axillary and infraaxillary region.
So, what will you find in nose in case of tuberculosis?
Ma'am?
Tuberculosis finding in the nose. Why did you examine for nose? Hello, audible, doctor? Kekda?
Hello, ma'am.
Kekda?
Yes, ma'am. Yes, ma'am.
Kekda.
Yes, ma'am. No, any devious net spectrum or any polyp present, any sinus present.
What do you want to find in nose? Nasal septal deviation, sinus tenderness.
No, ma'am. Any atropic in vagus granulomatous, we can see atropic turbinate, ma'am.
Was there any widening?
Ma'am?
Intercostal space widening irundha right side la illa?
No, ma'am.
No. Scars, sinus.
No, ma'am. No scars and sinus.
If it is present, what would be the inference?
If there is a scar and sinus, if the scar for any surgery or previous ICD insertion, it infers, ma'am.
Okay. When trauma can be also there.
Yes, ma'am.
Trauma scars
Yes, ma'am. Yes, ma'am.
long-standing pleural effusion
Yes, ma'am.
dilated veins over the chest wall any malignancies?
Yes, ma'am.
Any malignancies?
Yes, ma'am.
So we are seeing drooping of the shoulder?
No, ma'am.
No, not there here. If drooping of the shoulder is there?
Apical lobe fibrosis, it's a case, ma'am. Loss is there.
Intercostal space will be narrowed down.
Yes, ma'am. Yes, ma'am.
Sir, yes, sir.
The other causes for intercostal tenderness,
Other cause, any local inflammation or any osteomyelitis, any malignant infiltrations present, sir. Any trauma, any rib fracture can cause intercostal tenderness, rib tenderness.
Herpes zoster also, any infection over there. Herpes zoster kuda intercostal tenderness varala.
Yes, ma'am.
So you told the empyema, the patient is very sick.
Sir?
The patient is very sick looking and toxic.
No, sir.
To say empyema, the patient
is
sick looking and toxic.
Yes,
is the patient sick looking and toxic on admission?
No, sir. At the time, patient was not sick looking, sir.
So his main complaint is only breathlessness and pain.
Yes, sir.
So what are the other causes you have to suspect for empyema?
Any tubercular pathology we have to suspect, sir, this age group, and
no, is the patient undergone any diagnostic aspiration admission and after intercostal?
No, sir, he didn't have any iatrogenic cause in the past, sir.
In hospital admission second day, third day, any intercostal diagnostic aspiration was done?
Yes, sir. Yes, sir. Fluid analysis done, sir, under the ultrasound, sir, under the guidance of ultrasound, yellow turbid thick fluid aspirated, sir, and protein is 4.5, LDH is 1100, sir, and glucose is less 60, only 50 mg per day, sir.
Finding
and
has undergone any diagnostic aspiration?
Yes, sir, we have done diagnostic aspiration after admission, sir. And
So how will you differentiate tuberculosis empyema from other bacterial, suppose Staphylococcus pneumonia producing empyema,
yes, sir.
a parapneumonic effusion? So
It will have,
how
yes,
going to
sir.
differentiate? Is there any differentiating point to say tuberculosis empyema and other?
Yes, sir. Cell count will be increased, and which is a predominantly neutrophilic.
Clinical symptom and signs. Is there any differentiating point between tuberculosis empyema and the other?
So any external markers of TB present now, we can tell TB. Weight loss must be there, sir.
Usually, if the patient having parapneumonic effusion producing empyema, patient will be very toxic.
Yes, sir.
Since the parenchyma is involved, so patient will have respiratory distress and other things.
Yes.
But the tuberculosis mostly it is a sterile pus.
Yes, sir.
And the patient will be not that much toxic. With a malignant effusion with the secondary empyema, usually it presented with a massive effusion empyema, and patient will have respiratory distress.
Yes.
Okay, proceed. Lab investigation.
And CBCW leukocytes, there's a leukocytosis which is predominantly neutrophils, and hemoglobin is 13 gram, and platelets are 2 lakhs, and blood sugar is 110 mg per dl, and RFT and LFT within normal limits. ESR is 40 in half an hour, 80 in 1 hour, and CRP is 40. Urine routine is normal. Serum LDH is 250 unit per liter, and pleural fluid analysis done under the guidance of USG diagnostic tapping done. Yellow turbid thick fluid aspirate done, is aspirated, and protein is 4.5 gram per liter, and LDH is 1100, glucose is 50 mg per dl, and pH is 7.5, and cell count is 5700, which is predominantly neutrophil. Light criteria, it denotes, it shows a exudative pleural effusion. In pleural fluid cytology is predominantly neutrophil with a few mesothelial and lymphocytes. Pleural fluid ADA is only 20 international unit per liter, and pleural fluid CB-NAT negative, and pleural fluid gram stain is negative, and pleural fluid culture and sensitivity, that's no growth, sir. This is a CT chest of the patient, sir. We can see loculator, there's a split sign, sir, with yes, a split fluorescein with differentiating enhancement of pleural and the visual and parietal pleura on contrast, sir. And cardiac evaluation is normal. pH is less than 7.5, so mostly and with predominant neutrophilic cell with exudative, predominantly mostly due to the bacterial infections. So starting on empirical antibiotic, and intercostal drainage done, and the day of admission after pleural aspirate reports, and chest physiotherapy and intensive spirometry given, sir.
So what is life criteria, doctor?
Pleural fluid serum fluid protein more than 0.5, and serum pleural fluid LDH more than by serum LDH more than 0.6, or serum pleural fluid LDH more than 2/3 of upper limit. It denotes exudative pleural effusion.
So based on cell count, if the cell count is more than this value, we can say that it is an exudate. What could be that value?
10,000, ma'am.
Okay, so he was the pleural fluid culture was showed no growth, and he was started an antibiotic. He improved well.
Yes, ma'am.
With so CT doesn't show any parenchymal lesion.
Yes, ma'am. Yes, ma'am.
So then, what could be the reason for this effusion?
it may make a primary back empyema, ma'am. Because he's
Based on ADA, what is the criteria for diagnosing TB?
so more than 40 ADA is significance of TB. More than 70 is high priority, ma'am.
Okay.
Less than,
Along with ADA, more than
40, ma'am.
70 along with lymphocytes.
Lymphocytes. Yes, ma'am.
Lymphocytes.
Yes, ma'am.
So 40 with lymphocytes, probable. Less than 40, usually we say that it is negative. Even then, based on clinical grounds, we can start an ATT if he is having a long duration and that history fits into TB.
Yes, ma'am.
So did you follow the patient? Is he okay with antibiotic?
I mean, so he was responding antibiotic after third day itself, ma'am. There's no chest pain. The patient dyspnea also reduced, ma'am. We asked him to follow up again for after 1 week. We started an oral antibiotic and asked him to review to do ultrasound. Is there any reduced? We put ICD, ma'am. After that, because of pH is 7.15, ma'am, and even though it's no growth, we have to put ICD for the patient. And after 1 week, there's no aspirate came, ma'am. So
it was
okay. Yes, ma'am.
Okay. What if this is the case? So out of the case, so how will you proceed into a pleural effusion? Like a patient is presenting with pleural fluid, either on right or left or bilateral. How will you proceed with the case of pleural fluid or pleural effusion?
And first, we should see pleural fluid analysis, ma'am. Is the exudate or transudate, ma'am?
Yeah, take history.
With history.
With history, you are ruling out any systemic causes there for the
effusion. Yes, ma'am. If a patient presented with right hypochondral pain with fever, you may have a liver abscess. We should rule out a liver abscess, ma'am. We should rule out any pancreatic pathology in the patient. If you may got a pancreatic pleural fistula, we should rule out a trauma. And if there is a weight loss seen, if it can be malignancy or tuberculosis, ma'am. And yes, ma'am.
So if a patient is presenting with a pleural effusion, so just go into the history, ask what is the history, whether he is having any systemic illness like cardiac issue or renal pathology or hepatic pathology. If these systemic causes are there and the patient is presenting with bilateral symmetrical effusion, this could be due to the systemic cause related to so there we need to put the needle. So if we treat the systemic cause and wait for probably 3 to 1 week, 3 days, 1 week, it may resolve.
Yes, ma'am.
So even if in case of any systemic illness like cardiac pathology, renal or hepatic pathology, if the patient is presenting with unilateral or asymmetrical effusion with fever or with chest pain, we have to do thoracentesis and analyze pleural effusion.
Yes.
If the patient doesn't have any systemic illness and he is presenting either with unilateral or bilateral effusion, go for tapping.
Yes.
In tapping, if it with the Knight's criteria, if it comes to be transudate, we have to check what is the systemic cause, which is producing this effusion. It can be like, as we said, cardiac, renal, or hepatic, or any connective tissue disorders also. Then if it is an exudate, we very well know it could be due to any infectious etiology, again, connective tissue disorder, pulmonary embolism, and many lists are there. Okay. So first we have to rule out whether it is transudate or exudate. So if it is transudate, treat the cause, it will subside. If it is exudate, we have to find out the cause one by one, like based on the history also. Like in case of infection, he may present with fever for some days, like with chills, rigor, anything can be there. In case of any connective tissue disorder, he may present with joint pain.
Yes, ma'am.
joint pain, and there may be markers of any connective tissue disorders. And if it is due to, how will you differentiate this? Okay, how will you differentiate empyema and chylothorax?
In chylothorax, there will be a white creamy fluid, which will be there is a triglyceride elevated more than 110, ma'am.
In chylothorax, okay.
Yes, ma'am.
What are the causes of chylothorax?
It can be due to trauma, due to malignancy, tumor like lymphoma. It can be due to leiomyomatosis and
surgery can be the cause. When surgery is done and the thoracic
Yes,
duct is injured,
yes, ma'am.
we may get chylothorax. What
Yes,
is pseudochylothorax? Can this be pseudochylothorax?
Yes, ma'am. In long-standing pleural effusion, exudative fluidation can go for pseudochylothorax, where the same white color cream material will be there, but there will be no triglyceride, only cholesterol crystals will be there.
Will be there. It will be more than 200.
Yes, ma'am.
Huh?
Yes,
200. What is the easiest way to differentiate between chylo and pseudochylo? Simple thing. Take the fluid.
Yes,
Do
ma'am.
centrifugation.
Yes,
Okay. Difference between empyema and chylothorax. So when we do centrifuge, in empyema, the debris will settle at the bottom. But in chylo, there won't be any settlement.
Okay.
Throughout the thing, it will be milky.
Okay.
Okay. Okay. If it is a loculated effusion, how will you do a thoracentesis?
Under the guidance of ultrasound only, we should do, ma'am.
Yes.
As a recent guideline, ma'am. And then we should in loculated means we have to put ICD, ma'am, and a space of triangle, ma'am. Safe triangle, ma'am. When there is a more dullness, where the more spony dullness, we have to put there, ma'am. Under ultrasound.
Yes, sir.
Ma'am.
That's it. Right?
Hello.
Yes, sir.
How many percentage positive yield for tuberculosis when you do the pleural fluid for CP-NAT and staining for AFP? How many percentage will you get positive result?
So only 40% will get, sir, for CB-NAT, sir.
So then how will you suspect?
So we if you have strong suspicion, we should do only pleural fluid, pleural biopsy, and we should see culture it, sir.
Pleural biopsy.
Yes, sir.
How do you do pleural biopsy?
So video assisted thoracoscopy we should do, sir. And
so if you have any diagnostic dilemma or
yes,
the patient not improving with treatment, then the investigation of choice will be video assisted thoracoscopy.
yes, yes.
So which disease is a mimicker of tuberculosis in India?
Sarcoidosis.
Sarcoidosis. So to suspect sarcoidosis also, you don't get and malignancy like lymphoma.
Yes, sir. Yes, sir.
Effusion. If you don't get any improvement, you have to suspect. So how will you treat this patient?
So we should start. We should give antibiotics, cephalosporins, and with beta salpactums for pleural effusion before getting culture sensitivity. And we should, because it is a loculated effusion with the pH of less than 7.15, it's a complicated paradigmatic effusion. We have to put intercostal drainage only, sir.
This patient will start ATT or not?
I will not say because he is responding to antibiotics well, sir. And AD also, pleural AD also only 20, sir. So I will again after
with one level of area, will you say it is tuberculosis negative?
I will review the patient after 2 weeks and see whether repeat X-ray we'll see, sir. If resolved now, we'll continue the antibiotic for 2 to 3 4 weeks. After if there is again not resolving, we have to consider tuberculosis.
So what are the complications we'll expect?
So the patient will go pleural fibrosis you can go, sir.
Pleural adhesions.
Adhesions, yes, sir.
Fibrosis and the calcium.
Yes, sir. Calcium, okay. Fibrothorax you can go, sir.
Will you give anaerobic coverage in this patient, or will you give only the some sulbactam like that?
If there is an air in that fluid collection, we should suspect anaerobic organism. So then at that time we can give a metronidazole and clindamycin, sir.
So he is immunocompetent. So which bacterial infection likely to cause this empyema?
So most common is streptococci, sir, then staphylococci, and then E. coli.
Madam, ஏதாவது கேக்குறீங்களா?
What is the cause for loculation?
Yes, ma'am.
What is the cause for loculation? Loculation ஏன் வருது?
Ma'am, in the third stage of empyema, there will be the immune try to increase fibrotic secretion will be there, ma'am. So it will go for fibrosis, and so there will be loculate septably present.
Okay, in the visceral and the parietal pleura,
Yes,
there will be loculation. What phantom tumor?
Ma'am?
What is phantom tumor?
What is phantom tumor?
So I don't know, sir.
Vanishing tumor of the lung.
Vanishing. Effusion in the
Tumor.
Hello, sir.
What is vanishing tumor of lung? That's phantom tumor.
Yes, yes.
effusion in the mostly it gets resolved with, and in CCF there may be effusion in the fissures,
Yes,
which get resolved with diuretic.
yes, ma'am. Yes.
Giving diuretics totally vanishes. So
Yes.
it's known as phantom vanishing tumor. We may be taken that as mass lesion, and we may go for contrast.
Yes, ma'am.
என்ன முடிச்சுக்கலாமா?
Yes, sir.
If there is no questions, we can conclude.
Yeah, thank you, sir.
Thank you.
Thank you, Vijay sir, and Ananda Shuri madam for discussion about this pleural effusion of more of empyema. Thank you, Dr. Jagadish also. Thank you, sir.
Thanks.
Yeah.
Thanks.